This video will explain the signs, symptoms, and risk factors for different types of exertional heat illness. Demonstrate best practices for emergency treatment of exertional heat illness in the field, during transport, and in a clinic. And outline general steps for patient recovery and return to duty after an exertional heat illness event. Exertional heat illness is a spectrum of clinical conditions ranging in severity from mild to life-threatening. On the spectrum, heat exhaustion has signs and symptoms that are generally mild with a quick recovery. Heat injury has more clinically significant signs and symptoms. Exertional heat stroke is the most serious with risks for a long-term and possibly permanent end organ damage. EHS, if not managed aggressively, is a potentially fatal illness. Let's consider the signs, symptoms, and laboratory findings for each condition. Keep in mind that a service member does not have to pass through heat exhaustion and heat injury first, but can immediately develop exertional heat stroke. As with other clinical conditions, exertional heat illness will come with signs and symptoms. Signs are objective and can be observed by the provider, while symptoms are subjective comments and complaints by the patient. Heat exhaustion is characterized by signs such as tachycardia, orthostasis, diaphoresis, flushed skin, and most notably a rectal temperature equal to or greater than 101 degrees Fahrenheit and less than 104 degrees. Symptoms of heat exhaustion, as reported by the patient, may include mild headache, nausea, weakness, dizziness and tingling of arms and legs. Exertional heat exhaustion usually resolves rapidly on removal from the heat and minimal cooling intervention. Service members typically make a full recovery with a rapid return to duty likely. Heat injury is more severe than heat exhaustion. The primary signs and symptoms for heat injury are the same as heat exhaustion but may be more pronounced. Clinical evidence of end organ injury, including acute kidney injury, liver injury, or rhabdomyolysis, may be noted. Immediate steps must be taken to begin cooling and support organ function as appropriate. Exertional heat stroke is a life-threatening condition. Commonly, the patient collapses. The rectal temperature is usually equal to or greater than 104 degrees Fahrenheit. Additional signs include tachycardia, hypotension, diaphoresis, unsteady gait, combativeness, delirium, confusion, convulsions, or coma. If these signs are noted but temperature is normal, other potential causes need to be considered. In military settings, one relevant cause is exertional hyponatremia or extremely low sodium level. There is a risk of significant end organ injury, including cardiac arrhythmias. EHS can progress to a sudden, multi-organ dysfunctional state, evidenced by systemic inflammatory response syndrome, disseminated intravascular coagulation, and liver failure. Urgent steps must be taken to cool the service member immediately and begin life-saving supportive interventions as clinically indicated. Exertional heat stroke occurs infrequently in service members, but must be urgently recognized and treated when it does occur. Otherwise, it can result in a service member fatality. Exertional heat stroke remains one of the most common causes of preventable, non-traumatic exertional sudden death in the military. Between 2010 and 2015, the number of EHS incidents remained relatively consistent. More males have an incident of EHS than females, and they are often 20 years or younger. Exertional heat illness occurs most often with young military service members who have a limited state of acclimatization. It also occurs when there is a mismatch between their level of fitness and training, the intensity of activity or exercise, and the environmental heat load. But all service members, young and old, fit and less fit, are potentially at risk, and leadership needs to be alert to the signs and symptoms. Risk factors for heat illness can be divided into defined categories. Intrinsic or non-modifiable risk factors may be congenital, genetic, or may be acquired. Extrinsic or modifiable risk factors include fitness level, body mass index, state of acclimatization, sleep deprivation or fatigue, hydration status, recent or concurrent illness, use of medications, dietary supplements, alcohol use, environment, clothing, work efficiency, and the operational tempo of the activity. In military settings, physical activity, protective gear, and conditions like high air temperature, high humidity, low air movement, and radiant heat from the sun all contribute to the environmental heat load. Human sweat glands are designed for cooling, but the sweat must be able to evaporate. Sweat that drips off the body or soaks clothing provides no cooling benefit. Under extreme conditions of exertion in the heat, even healthy, well-acclimated, and physically fit individuals will ultimately store excessive heat, which will cause the body temperature to rise. Some service members are not able to sustain work in the heat. Their body temperature starts rising earlier and at a higher rate than others under the same conditions. They may not be adequately acclimated, or they may just be heat intolerant. There is no way to know if someone is heat intolerant until symptoms of heat illness appear, so awareness and prevention are key.